I gave a talk about optimizing the care for MS relapses, and I talked about what a relapse is, and definition as a relapse is a patient with MS who describes a worsening of their symptoms with or without objective clinical signs which last over 24 hours. I did say that this seems a fairly clear-cut definition, but actually in reality it's incredibly difficult to often know what's a relapse, a pseudo-relapse, or something that's just a fluctuation in the patient's general condition. And that's one of the challenges of deciding whether someone's having a relapse or not, and whether they need treatment. I emphasised the importance that relapses are just the tip of the iceberg of the MS disease activity, and that we should really look at relapses as a signal that this patient's disease is not controlled, and that whatever disease modifying therapy they're on should probably be reviewed and an alternative considered. This is important because it's been shown that just a single relapse can predict the patient is going to do badly and progress with their disease. So it's not that the relapses tend to cause the disease progression, but they're a signal that the disease is active. So when a patient has a relapse, not only do they need to be treated for it with corticosteroids if they have any disability, but also need both physical and psychological support for that, because it can be a very disheartening experience. So it's important to give them that support. The next part of the talk was really about the service and developing the service. The key part of it is really about access. Patients need to be able to contact someone to discuss new symptoms, to establish whether it's a relapse or not. And that should then enable an early either remote telemedicine or physical review to assess whether this is a relapse or not, and then allow them to proceed, if necessary, onto corticosteroid therapy. I talked about the evidence for intravenous versus oral therapy, and I think it's really fairly established now that the oral therapy is as effective as the intravenous therapy. And then I talked about the hazards of treating with corticosteroids for MS relapses. There's the less significant side effects, such as insomnia, metallic taste, and then there are the more significant things such as mood disturbance and also avascular necrosis of the hip. Then osteoporosis is more related to your mobility than actual number of steroids that you've been given. Therefore, while there are serious consequences to the high-dose methylprednisolone, they should always be balanced with the disability the patient will be suffering and the fact that the relapse can reduce the disability burden for the patient in the short term. And both NICE and Cochrane recommend the use of high-dose methylprednisolone for patients with MS relapses. Lastly, we came to the discussion about the service, and we discussed in a group about the different service models, but really the model has come down now to the MS nurse really being pivotal to it, to making the patient making initial contact with the nurse assessing the patient by telephone, and then advising about an early assessment to see about treating the relapse. Relapses predict disease activity and they predict future disability. Therefore, we should have really zero tolerance for relapses. We now have many disease-modifying therapies which are highly effective and can prevent relapses. So if anybody is having relapses, their current treatment plan should be reviewed. As for providing a relapse service, the key to it is accessibility, and also about patient choice of accessibility, in that we should make available both telephone, email, and if other technologies are available, they should be made available for patients to contact MS nurses easily so they can be assessed early for their MS relapse.